So So I'm Helen Yeung. I'm a pediatric ophthalmologist. It's definitely an extreme pleasure that I have the chance to speak to you all. Thank you, Whitney, for the invitation. I've known some of you all during my residency training, and it is a thrill. I'm really happy to be able to speak to you about things related to the eye. And some of the things today we will be talking about include pediatric vision screening and common eye conditions in children. There is a lot of information, but I hope if we can try to make this as interactive as possible in terms of, I know you all might have some questions. So hey, Natasha, I don't know if it's helpful, like, are you able to help me like toggle back and forth for questions? Because it's going to be hard for me to basically go between the chat while I'm presenting. So thank you so much, Natasha, really appreciate it. Okay, so to get started. Okay, so this is the protocol, the 2022 Massachusetts Vision Screening Protocol, which was just updated 2 years ago. So there are a couple of things that it says that in the state of Massachusetts that we should follow in terms of vision screening. So the critical line standard for children and adolescents for chart-based screening only for three-year-old and upwards. Well, for 3-year-olds is 2050, 4-year-olds is 2040, and then for 5-year-olds through grade 12, it's 2032. And then in preschool children ages 3, 4, and 5, that vision should be screened annually starting the year that they enter school. And then visual acuity charts, which I have, sorry, it's really small down there. So there's the layer charts is basically the circle, the heart, the square, and the house. And then that's the Sloan letter charts, which is basically similar to the Snellens. So the visual acuity charts should be using the Logmar notation and scoring. So number 4, regarding the near vision screening, that should be conducted annually on children beginning when they enter school through grade 3, so from ages 3 to 9, and near vision screening should be conducted at 16 inches. And then also as well in terms of distance visual acuity screening, that should start at 3, 4, and 5 years of age. It should be performed at 10 feet. And then number 6, stereo acuity screening is screened using this PASS-1 test. And I have something different in the office, which is titmus testing and also Lang testing, seeing the butterfly or the fly. I think because I don't have this test, it's you see the happy face or not in terms of stereo acuity testing, and that should be used for children's ages 5 through 9. So I know a lot of you all, I've worked a lot with the MGhC group and also Whitney's group that they've used this Welch-Allen vision screener. So I have that pictured there. There's many different ones. So for instrument-based screening devices, this should be used in children ages 3, 4, and 5. So something of note, with the distance visual acuity screening and stereo acuity screening, that's not required when you use the instrument-based screening protocol in this age group, but don't forget that you still have to check near vision acuity when you are doing the instrument-based screening. And then lastly, the last point that was made in the protocol is that the vision testing machines are now discontinued. So that was a bit about the protocols in Massachusetts, but I thought maybe we could transition to something a bit more interesting in terms of case studies, discussing about some of the common eye conditions that we see with children. So before we get into that, just a quick review of the anatomy of the eye. So this is a picture of the eye. So the outer layer consists of the cornea and the sclera, and then the middle layer is the iris, the ciliary body, and the choroid, and then the innermost layer is the retina. So this is the first case. This is an 18-year-old girl that was otherwise healthy, that she was cleaning, and then 1 hour prior to the exam that there was bleach that splashed her left eye, and this is what her eye looks like. So this is quite an emergency. So you can ask for additional information in terms of what like what if she has a bottle, what was splashed into the eye, if she knew what the liquid was when that happened. But really the most important thing to be done in the office is starting irrigation immediately with normal saline or anything, because the issue is that basic substances really damage the eye. So if you can try to get a vision, but really the most important thing to do first is to start irrigating. The other thing, I know that like you all have the litmus testing in terms of checking the pH in the urine. You can use that as well to check the eye to see whether or not whether or not the pH is still over 7. Either way, it's really important. Just keep on irrigating, and basically call and have them transferred to, immediately to be seen. Again, like these are case studies, so if you all have any questions, or Natasha, are you keeping track if there's any questions? Please definitely interrupt me, because I want to try to make sure that I answer any questions that you all might have. So this is case 2. So this is a 10-year-old.
Helen, can I ask a question about that eye flushing?
Yeah, sure.
Just curious, like, so I think that this might come up, right, like with a nurse triaging a call like this. Do you think, so say this is a patient who lives, next to our clinic, right? The value of having them come right next door and starting irrigating immediately versus like having them just go to the ED.
No,
kind of like that.
You make a very excellent point. Get started irrigating immediately. It does. If you have those like saline flushes, just or if you have like a bag of saline, just spray them. Spray that eye, because it's really, really important that you get the pH down to 7 rather than wait there and wait for them to be transferred. That's an excellent point. Excellent point. Natasha, are we good? Any other questions about this?
Nope, no other questions.
Yeah, no, but definitely feel free to interrupt me at any time about anything that we talk about, because I want to make this helpful for you all, especially if there's any questions about like meds or, things to do to recognize or diagnose things. We'll keep on going, but feel free to interrupt anytime. So this second case, it's a 10-year-old boy that was otherwise healthy. One day prior to a presentation, that they were having a history of foreign body sensation, tearing, discharge, redness, and pain in the left eye. So what could this be? This could be a number of things. So we want to get additional information. So some things to ask. So this is a 10-year-old, so I know they're kind of young for contact lenses, but you might all have heard of, there's some parents in terms of myopia progression, they might have seen another eye doctor that prescribed Ortho-K, which is a contact lens that you wear at bedtime to try to stop the progression of myopia. So younger kids might be wearing contact lenses because of that, but either way, knowing whether or not they have worn contact lenses in the past, present, to say, or any sick contacts in the family, at school, in terms of viral etiologies. Foreign body, sometimes that can happen. They're walking outside and some metal thing got, like a small speck of metal gets blown into the eye. That can happen. So what to do next? So if you can, check a vision, make sure the vision is stable, or ask them. I don't know if you all have topical anesthetic in the office. So if it really hurts, it's helpful to put a drop. This is for diagnostic purposes. I would never prescribe proparacaine or tetracaine for a parent child to take home to use. Yes, it makes them feel better, but the thing is that it could hurt the corneal, the outer layer of the cornea, the epithelium, in terms of getting the outer surface of the cornea to be better, to get better. So that would be something that I would never prescribe. It's just for diagnostic purposes if you have it in the office. And then in terms of treating with antibiotics, so I prefer, in terms of for younger children, I like to use antibiotic ointments, such as specifically polymyxin bacitracin ophthalmic ointment rather than erythromycin, because I believe that treats staph and strep better. But I mean, the other thing is that sometimes the pharmacies don't have that available. So whatever you can get, rather than, I'm not a fan of using Polytrim. I rather use a quinolone quinolone. My preferred quinolone is moxifloxacin. But in younger children, ointment 3 to 4 times a day. In older children, especially if they need to go to school, the ointment can be it's petrolatum based, so it's very sticky. So it gets really blurry, their vision, if you use it throughout the day. But it does, because it lasts longer, it will make them feel better. So for older children, I would prescribe it like at bedtime, but then afterwards during the day, use antibiotic drops. So
we have a question.
Yeah.
Can
Sure.
visual acuity be checked with Welsh-Allen machine in these situations, thinking smaller, less cooperative children?
So my understanding of the Welch-Allen screener is that it checks for refractive error. So when you see the report, it might have like a minus number, plus number, or actually it does minus cylinder. So it's a minus number or plus number, and then the second number is a minus number at whatever axis. So that's actually a refractive error. That's not a visual acuity. So visual acuity is actually basically having them look at the chart and basically seeing how far in terms of lines it could go down. So refractive error, different from visual acuity. So visual acuity is like 20/20, 20/200, 20/50 versus a refractive error measurement, which is what these screeners do. They give you what it is like in terms of like a ballpark of what their need for glasses is, and that's a glasses prescription potentially. So
sorry, that was my question. So maybe we can clarify a little bit about that, because I think this came up in our office about the difference between refractive error and acuity. Is there like a formula that translates between the two?
No, you just have to check it. You just have to check it. Yeah, because I mean, like, you'd be surprised. I mean, like, I have some kids that like they have they come in, they're 20/20, and then afterwards I put the cycloplegic drop, and then I check to see what their need for glasses is when their lens is relaxed, when their accommodation is relaxed, and they might be like a -1. So like, or potentially like even for the ones that have hyperopia, they could be like a +3. So it doesn't necessarily translate, the refractive error translate to what the acuity is. So you actually have to test it. So, which is, I know, it's very confusing.
Shannon just wants to clarify. So we are not checking visual acuity currently using the Welsh-Allen machine.
Yeah, so if the printout comes out and it's like, like a minus something plus something, like for example, minus 0.75 minus 0.25 at 180, that's a refractive error. So that's like, what it's kind of predicted refractive error if they need glasses or not. So it's not a visual acuity. Visual acuity is like, you're going up to, like, you're having them stand 20 feet away from the chart, from the Snellen chart, and you're having them, if they can read the EG NDH line, then they're 20/50. If they can see the TZVECL line at 20/20, that's the 20/20. Their visual acuity is 20/20.
So is the way we're screening more sensitive than a visual acuity? Like, are you saying kids can read the 20/20 line who may in fact need glasses?
Yeah, actually, I think I don't remember if it was one of your patients or Annie's patients that I've screened. Like, they keep on, I think they had trouble with your screener last year, and when I put the cycloplegia in, they were a higher plus. I think that child is like 10 years old. I think their refractive error was like a +3, but the astigmatism wasn't an issue. But even though they're a +3, like the screeners, what I tell parents all the time is that it's not perfect. It's set to a certain limit. But the thing is that child, even though they're like a +3, they're a higher plus, he's able to accommodate to see to 20/20. So, he, again, this year, he was put up to the screener and he didn't pass again. So he came back again. And again, he's 20/20. He had full stereo acuity. He was down to 40 seconds of arc. His eyes were straight. And then I dilated it again and used the cycloplegic drops, and still he was on a higher side of plus. But the thing is that there's really, I wouldn't prescribe that because, he sees 20/20, has excellent vision, distance, near, and full stereo acuity. So, it's not perfect. It's set at a cutoff. So that's why, we have to make sure, that is the case. So that's why, again, that the refractive error doesn't translate to what a visual acuity would be. You can't, there's no formula for that. You have to screen them, basically. Other questions?
Helen, Shannon sent the AAP guidelines for vision screening in the chat, and asked, so should we use chart-based for older kids and ditch the Welsh Allen for older kids? Or for younger kids?
So also the other thing is that based on the guidelines, for Massachusetts, that, for the younger kids that, you could definitely use that. I feel that, even in the older kids, the other issue is that it takes time to screen in terms of your, to check a visual acuity. So I don't know for all of your offices who is actually testing the vision. Because the other thing is that, the vision screener, basically it's very, if you just put the child into the screener, if it reads, then you're perfect. But the thing is that vision acuity screening depends on, who's screening it. Sometimes it can take time, and, again, I don't know how, who does the screening for your offices? Is it the medical assistants? Is it the nurses? Because sometimes you can also get, false positives as well of the visual acuity is not screened correctly as well. The distance might not be right, or, the letters on the chart size might not be right. I've had a number of kids that were referred from Chelsea, and they primarily just use their Welsh Allen screener, and that actually has been quite very on target. Actually, I could tell you that about 95 to 97% of the kids that they screened with their Welsh Allen screener have needed glasses. So, I know that they see a lot of patients because that's where my primary care clinic was when I was a resident. So, it takes time to screen, but if you don't have time to screen and your ancillary staff is able to basically accurately do the vision screener, then it's better than not doing it.
So can I ask one more question and then we can let you move on? So it sounds like the Welsh Allen is an assessment of the eye, and the visual acuity is an assessment of function. Does that make sense? So doing the visual acuity during an acute incident makes sense because that may change, whereas the Welsh Allen's just telling you the shape and function of the shape.
No, you're correct. You're correct.
Okay.
You're correct. That is exactly correct. That's exactly correct. So, because the vision can change, but the refractive error, whatever the machine pops up, usually doesn't change. Usually. So, but that's exactly correct, Whitney.
There's one more question.
Sure.
Can you confirm also that the Welsh Allen screener adequately screens for, Shannon, I don't know how to pronounce that one.
Amblyopia.
What?
Amblyopia?
Oh yeah, actually, it's actually very, what do you call it? Again, I've gotten recently a lot of patients from Chelsea, and it's very quite accurate actually, because even down to, I could remember there was this, I recently saw a 2-year-old, and they were concerned because one eye was more myopic than the other eye, and the screener picked up on that. And actually there was actual pathology in the back of the eye. They had a staphyloma in the back of the eye, and that's why they were -10 in one eye. And then the other eye was basically didn't need glasses. So the screener was very accurate on that, actually, in picking it up because of the difference in anisotropia between the refractive error being different in both eyes. So I in my experience with a lot of the Chelsea patients, it's actually been very good, very, very good, and very on target. So we good on that, or because there's some other stuff to go through that you all might have some questions on. So Natasha, what do you think?
Good to move on.
Okay, cool. So this is a 3-year-old. So not 3-year-old, this is case 3. So this is an 8-year-old that was healthy, that was 3 hours prior to the exam, was hit by a baseball to the right eye, and this is what the eye looks like. So this is what we call the hyphema. This is blood in the anterior chamber in the front of the eye. So what additional information should we ask about? So is there any pain? Is there any nausea or vomiting? Because this can cause an increase in the eye pressure. And again, is there any change in the vision that the child might have noticed? So if you see this, definitely refer this off as soon as possible, same day. Okay, so this is a 19-year-old girl that was otherwise healthy. 3 hours prior to exam, was punched in the right eye during an altercation during a fight. And this is what the eye looks like. So this is not good. This is what is a ruptured globe. And to add, the patient said that they felt that there was a gush of fluid that was coming out of the eye. So basically, this means that the eye is opened. So these are other examples of what a ruptured globe can look like. So basically, that the eye is opened, which is really bad, and that is a emergency. So what to do next? So plus or minus checking a vision, more like immediately placing a plastic shield on that eye because the eye is soft. You don't want to apply pressure to the eye because then the contents can come out, which would be bad. And that's a form of a plastic shield or a Fox shield, which is metal. Make sure that you tell the patient, the teenager or child, that they have to be MPO because they are going to surgery immediately the same day. And of course, refer immediately. So case 5, this is a 7-year-old boy that was otherwise healthy, that was having 3 months of difficulty seeing far away in school. So what is some of the additional information we should ask? So whether or not they noticed a change in their vision recently, were they able to see totally fine far away prior to that? Whether or not there's any pain, foreign body sensation, any history of trauma, what to do next. So if you can, you can check with the vision screener to see what their refractive error is. I mean, if they pass, then it's basically they're good. Or, if you don't have that, then you can just put them up and check their vision with the Snellen chart, and then referring them for a non-urgent complete eye exam. So this is case number 6. This is a 15-year-old that has a history of myopia and 2 days of seeing lights and a curtain coming down in their left eye. So what could this be? So some additional information that we should ask about first is, have they noticed a change in their vision? Is there any history of trauma? And what do we do next? So checking the vision, telling them to basically MPO, because what we are worried about is a retinal detachment. So which classically patients will tell you that they're seeing flashes and floaters, they have decreased vision, they have a loss of their peripheral or central vision, and they see a curtain coming down. So that's also, they would go to surgery on the same day. And that's why it's really important to tell them to MPO if you have any concerns about that, and of course, refer them off. So any questions as of so far?
None yet in the chat.
Okay, cool. Thanks, Natasha. So this is case number 7. This is a 12-year-old female that was otherwise healthy with 3 weeks of a history of a right upper lid redness without tenderness. And this is what you see on exam. So what could this be? So what other questions should we ask from the parents in this 12-year-old? is there any change in the vision? Usually there's not, but if it's been there for a long time, so this is a chalazion. So this is usually a result of having a hordeolum, which is a sty. And then basically what is left is basically inflammatory tissue, lipogranulomatous tissue. So if it's been there for a long time, sometimes it can cause astigmatism. So asking if there is any change in vision. Sometimes it can spontaneously drain. And then what do we do next? So again, if we can check a vision. So warm compresses. So there's many different techniques of warm compresses. So you can do the potato slice method, basically anything that holds heat, not using a towel and running to the sink constantly, that doesn't hold heat that well. So the potato slice method, it holds heat like okay. The tea bag method as well, it's kind of, that's okay. I usually prefer, I tell the parents to get a warming eye mask that you can get on Amazon, or even you can go to the pharmacy and get a sty pouch that has, it's like a little pouch with beads that you can put in the microwave and heat up. Because of course, like, before you use it, that you should check to make sure that the temperature is appropriate before putting on the eyelids, because you don't want to burn the eyelids. But the thing with the sty pouches and also with the sty heating mask, or not the sty heating mask, the eye heating mask, is that it holds heat longer. So when it holds heat longer, it basically allows there's these glands in the base of the eyelashes. So basically they're clogged. So when they open, it allows the contents to drain. And which is basically what we would do if it's been there for a long time, that we would take them to surgery to drain the lesion. So if they can compress and like keep it on for a long time, that would be very helpful. And then refer, like, if there's any question, then definitely refer for a comprehensive eye examination. So that were,
can I ask a question? How long would you allow a patient to, have conservative management? Like, at what point should we refer for that?
So that's an excellent question. So if they're doing the appropriate things in terms of the heating as much as they can, it is expected that the chalazion would go up and down in size. I'll talk about it as well. I have another slide about it as well, in terms of also taking omega-3s, which is fatty acids. That's also very helpful in terms of modifying like what the glands, those at the base of the eyelashes, what they're producing, because when they're blocked, they're basically excreting, it's kind of like this cheesy solid substance. What it usually supposed to do is that it's supposed to excrete this like oily kind of like olive oil material to cover the cornea to keep it from being dry. But getting back to your question, if it's been months and it's still the same size, and the parents are not happy with the fact that it's still there, then it's appropriate to refer. And then afterwards, that we would have a discussion with the parents, because in terms of draining it, that it would be under general anesthesia. So again, it's a lot of chronic management, because I would explain to the parents, like, just because we take care of one doesn't mean that it's not going to come back, and it's not feasible to be constantly taking a child back under general anesthesia to incise and drain these things. So that's why compressing is very important, but again, using something that holds heat for a prolonged, like a longer period of time, with the eye mask or sty pouch. Omega-3s are very important. They come in different forms. Usually I like the liquid form, or if they can take a pill, it has a higher content of omega-3. And that helps in terms of preventing these things from coming back, both styes and chalazion, hordeola and chalazion. And then also cleaning their lashes. So I'll get to that in a couple of slides. So that's a great question. And Natasha, anything else?
Nope, nothing in the chat.
Okay, so something commonly that is seen in children, younger children, is a nasal lacrimal duct obstruction. So now transitioning from the cases, just talking about other things that I know you all commonly see. So for an NLDO, nasal lacrimal duct obstruction, so usually this is present at birth, but it might not manifest at birth. That after a couple of months that they start having crusting of the eyelids, usually especially upon awakening from overnight or from a nap, and they usually have discharge and a lot of tearing. So in terms of treatment, what to do, wipe away the discharge. So it's not necessarily a massage, it's more a compression of the sac, which is helpful to get basically the discharge out of the sac, because the more bacteria basically that is inside the sac, if you don't express it, then basically that it's going to stay closed. And more inflammation, bacteria causes inflammation, so then inflammation causes the valve, or basically it causes more of an obstruction. And then I would recommend BID to TID compressing the lacrimal sac, and then after compressing, then putting polymyxin bacitracin ointment in order to clean everything. So the best video I could find online was this video from India that shows how to do the lacrimal sac compression. So we'll just take a look at part of this.
Hello everyone. Today, let us understand the correct technique of lacrimal sac compressions done on a child less than a year old and suffering from continuous watering from the eyes. The first step is to hold the child firmly. Hold the head and make sure the head does not move while doing the compressions. Now use your index finger to do the compression. Make sure that your nails are trimmed. Feel for the edge of the bone next to the nose and below the eye. Using firm pressure, gently press towards the nose, directing force slightly inwards. Continue these compressions 10 times per sitting. At least 4 such sittings per day have to be performed. A crying child should not be a cause for concern and should not be a reason to discontinue compressions.
Okay, so then afterwards, the video will tell you to try it on yourself. So it is true what they said, that it does not hurt. It's just that the child is upset because their head is being held. But it's very helpful because you'll be able to, when you push, you'll be able to express any discharge within the sac, and if there's any reflux tears as well, it allows for potentially the duct to open up before 12 months of age, so that if it doesn't open up after that, then the child would need a probing. So questions about that?
Compression.
Any questions about that, Natasha?
Just Dan making a comment. This baby is really enjoying the massage.
It doesn't hurt if you do the same thing on yourself. It really doesn't hurt. It's just they don't want to be held. So it's just very, very important that we teach the parents how to do this properly, because it gives a higher chance for the duct to open by itself, so that come time when they turn 1 year old, there is a potential that they can basically spontaneously open. So then we don't need to bring them to the OR under general anesthesia to do the probing. So okay, so a couple other things. So something else that we commonly see, so a subconjunctival hemorrhage. So basically this is a bruise on the outer side of the outer portion of the eye. So patients would say that they would have redness. Usually it's not associated with changes in their vision. There's no history of trauma usually with this, but there can be a history of Valsalva, for example, if somebody has constipation or if they've been eye rubbing a lot. So things basically to tell the parents that, this is a bruise on the outside of the eye. Reassure them everything's going to be okay. And it might start spreading because there's a limited amount of space that the blood can go. It might look really horrible, but it will eventually get better. If the subconjunctival hemorrhage is really elevated, if they have difficulty closing their eyes, artificial tears lubricating ointment can be recommended at that time. Conjunctivitis. So conjunctivitis, it can, in younger babies, it can be bacterial, especially if they have a lot of discharge. And in like children, like, school age, viral is very common because there's sick contacts. It starts in one eye, then goes to the other eye. So the kids can experience redness. They can experience itching, crusting, discharge, tearing. Topical antibiotics is very helpful. Again, I prefer the polymyxin bacitracin ophthalmic ointment that can be used. You can use it like definitely at bedtime, and then during the daytime use moxifloxacin 3 to 4 times a day, or you can just use the ointment 3 to 4 times a day throughout the day. If it is viral, then make sure that you tell the family that they have to wash their hands. Basically don't touch their face, because we don't want other members in the family to get it and spread it around. So versus a corneal abrasion. So corneal abrasion, oh, was there a question?
Yes. I haven't typically prescribed topical antibiotics for NLD unless also with eye redness and worsening discharge. Do you recommend this for all infants with NLD, and for how long, since symptoms are typically ongoing and they eventually outgrow?
So I wouldn't, my preference is I prefer ointment over drops for nasolacrimal duct obstruction. So if there is discharge that is coming out of the eye, then I would tell the parents, I would recommend that they do the compressions, if they can, 3 times a day, like with each meal, morning, breakfast, and dinner, and then apply the ointment. But if it's such that, after a while, when they're compressing and they're, nothing is coming out, or they're just getting clear tears, no mucus discharge, then it's okay not to give them the antibiotics. But usually in the initial period, when they have tons of crusting, when they wake up in the morning, and then when you do the compressions, there's usually some pus, like, mucus discharge that comes out, which is a sign that there is bacterial infection. So, ointment is better because it gets down into the duct, and it lasts longer.
Helen, there shouldn't be much concern for like resistance to one type of treatment versus another in terms of bacterial conjunctivitis. We had a lot of daycares this year, like demanding erythromycin because they said nothing else was working, which I sort of took as just a bunch of viral conjunctivitis. But
yeah. I mean, the thing is that, like, if it's viral conjunctivitis, technically with time it will get better. So, you could even, especially like classically viral is, like it starts in one eye and then goes to the other eye. They might have a tender preauricular lymph node as well. Theoretically, it will eventually get better, but just to help them symptomatically, because the eyes can get really dry with conjunctivitis. I mean, you don't necessarily even need to give them an antibiotic. You could just give them like an artificial tears lubricating ointment. There's multiple brands. It could be like Refresh PM, Sustain, Hylo, just basically just to help them symptomatically in terms of that, like, the foreign body sensation and the pain and the tearing that they might be feeling. So, I feel like everybody's using erythromycin ointment already. So, like, I think mostly the erythromycin is because it's petrolatum based, that it's helping symptomatically what the child is feeling. It's not necessarily making it better, because eventually it will get out of their system. But if it's a bona fide bacterial conjunctivitis, which is usually it just is in one eye and it has a lot of discharge, then definitely polymyxin bacitracin ophthalmic ointment, I think, is better than the erythromycin.
Helen, can you comment on subconjunctival hemorrhage and risk of child abuse?
Okay, that's an excellent question. So the thing is that usually with child abuse, like, there should be a history, like, of trauma. So, like, if there's a history of trauma, I mean, of course, do a full physical examination. But, if it's otherwise, like, if it's a very innocent history, it like, spontaneously occurs, like, if, child is like, especially with the allergy season, if they're rubbing their eyes a lot, they can get a subconjunctival hemorrhage. But I think the key is there a history of trauma, and doing a full, body physical examination to see if there's any signs of that. We good? I have a couple, we're going to be going over time, Natasha. What are your thoughts?
Is there anything this group, any pressing questions, or should Helen continue going? Helen, maybe,
Yeah, I mean,
what are the rest of the
Yeah.
topics? Maybe that.
Okay, so conjunctivitis, we've already talked about that. The corneal abrasion, so that the major take home for this one, the key thing is that it hurts a lot, and they get, again, like same thing, like foreign body sensation. They can be very photophobic, tearing, same thing. Ointment, I think, is better because it lasts longer. But in a child that has to go to school, then giving antibiotic drop throughout the day during the daytime is helpful, and it should get better in a couple of days. So versus dry eye, the difference is that there's usually no discharge for this, and basically lubricating the eyes with just a regular artificial tear ointment and artificial tears. I like preservative free, especially if we're using it like very frequently, because it's better for the cornea. So just a quickie on this one, just because we don't have that much time left. So a hordeolum versus a chalazion. So a hordeolum is an active infection of the eyelid glands. So basically the difference between a hordeolum and a chalazion is that it is tender to palpation because it is an active infection. So in terms of treatment, I would recommend prescribing a systemic antibiotic because, again, if you ask multiple pediatric ophthalmologists, we all treat it differently, but I feel like, we should treat it, basically strong in the beginning and then afterwards taper off, because we don't want it to become a chalazion, because a chalazion can take a long time to get better, even with the compressing. So I would treat it with cephalexin by mouth, and then afterwards prescribe the antibiotic ointment, and also as well warm compresses with something that holds heat. So again, versus after the hordeolum, it becomes a chalazion, which is non-tender. Always telling the parents that it takes patience for it to get better. Compressing definitely helps, omega-3 fatty acids, but usually all of this comes from, like, a lot of these kids, the lashes are not clean. You see there's this dandruffy material, which is a sign of bacteria or blepharitis. So cleaning, doing lid scrubs with, I like the tea tree oil wipes, because it really gets to where all that dandruff is stuck at the base of the lashes, and that's the reason why they are getting hordeolums that become chalazions perpetually. And then preseptal orbital cellulitis, I'm sure I remember in residency encountering as well the ones that come in for IV antibiotics because of a concern for orbital cellulitis, because their extraocular movements are not intact. But if they are, which is still preseptal, then you can give PO, amoxicillin clavuronate, and then refer if there's any concerns of orbital cellulitis if their extraocular movements are not intact. And then strabismus. So strabismus can come in. They can come in many different flavors. The eyes could be going in, they could be going out, they could be wandering, they can go up, they could go down. Asking the parents, when did this start? Is it becoming more frequent? Are there any patterns? But basically, in terms of referring them off, because you should get a comprehensive eye exam, including a cycloplegic refraction, to know whether or not, because sometimes, especially with children that have their eyes turning in or even out, sometimes they do need glasses. And then that once when they get the glasses, that they should be encouraged to wear the glasses all the time. And then coming back for eye exams to have their vision checked, because sometimes even with the glasses, one eye sees better than the other eye, as Shannon mentioned, like amblyopia. So starting patching, patching, and then encouraging the family to follow up on the patching because it can make a difference to make the vision equal in both eyes. And then in terms of surgery, that's if there's still an eye churn after doing all those things. So that is basically, I know there was a lot of stuff. I did really do appreciate, the interaction, because I want this to be helpful to you all, because I know you all, these are the common things that you see with your patients. And of course, as I remember during pediatric residency, that, there's no such thing as a stupid question. So, definitely if you have any questions, you should always ask, because we're all here to, help our young patients, and, we want to do what's best for them.
Helen, thank you so much for your time today. For those still on the call, if you do have any questions, definitely send it our way. I'm happy to send them over to Helen. We will have her slides as well as the recording and share that once we have the YouTube link. And it will also be in the scoop that Alexi sends out every month. Helen,
Thank you
again.